Good morning, everyone. My name is Camilo Gonzalez Velasquez. I am the co-host of the Thyroid by MD's webinar series, and thank you for joining us today for our this Friday morning's lecture. Today's we will focus and discuss the use of post-operative calcitonin in medullary thyroid carcinoma. And I'm honored to introduce you to three fabulous and distinguished guests that we have. First, we have Dr. Luiza Maia. She is professor of medicine at the Universidad Federal do Rio Grande do Sul and head of the thyroid unit at the Hospital de Clínicas de Porto Alegre in Brazil. A thought leader in type 2 medullary and multiple endocrine neoplasia, and she's also former president of the Latin American Thyroid Society. Additionally, Dr. Rafael Scheffel, an associate professor at both Hospital de Clínicas de Porto Alegre and the Department of Pharmacology at the Universidad Federal do Rio Grande do Sul. He specializes in thyroid disease research, and he currently serves as the vice president of the thyroid department at the Brazilian Society of Endocrinology and Metabolism. Finally, Dr. Sana Ghaznavi, trained in internal medicine and endocrinology at the University of Calgary, and she later completed an interdisciplinary thyroid cancer fellowship at Memorial Sloan Kettering Cancer Center in New York City. Her practice focuses on thyroid cancer management, and research interests include active surveillance of low-risk thyroid carcinomas and thyroid cancer survivorship, as well as pathways for anaplastic thyroid cancer treatment. Before we begin, I would like to encourage all of you to send your questions through our Q&A function, and we'll try to address as many as we can by the end of the hour. So without any further ado, Dr. Maia, please, the mic's all yours.
So good morning, everyone. It's my pleasure to be here today to address introduce some discussion, some data about calcitonin as a marker for long-term survival, free of disease in medullary thyroid carcinoma. I am like Dr. Camilo just introduced me. I am a professor of endocrinology in the Universidade Federal do Rio Grande do Sul that is located in south of Brazil. Okay, so these are my and Dr. Rafael disclosures. So since we are both co-authors of this manuscript, this paper, we thought it would be interesting to divide our presentation to do it more dynamically. And so I will introduce the data, the literature data that prompted us to design this study, and Dr. Rafael will present the data itself. Before we start, I would like to acknowledge Dr. Marta Amaro da Silveira Duval, that was a postdoc in our lab, and who is the first author of this study that was her PhD thesis. Okay, so just to contextualize the focus of this manuscript, we all know that medullary thyroid carcinoma is a rare thyroid C tumor, originally, or is a hairy tumor originally from the C-cell malignant the C cells from the thyroid gland, and accounts for nearly 3 to 4% of all malignant neoplasias of these glands. Calcitonin is the most important biomarker because it is specific. We do have also the embryonic antigen that is also a marker for this type of cancer, but it is also a marker for other types of neoplasias. One important thing to highlight here is that the medullary thyroid carcinoma can appear like an hereditary, inherited form that is part of the multiple endocrine neoplasia type 2. In this case, this comes associated can be associated with two other tumors, like the pheochromocytoma and hyperparathyroidism. So this syndrome has an autosomal dominant inheritance, as you can see, and it means that each child from an affected father or mother has a 50% chance to have the disease. And important also to point that the penetrance of these genes is close to 100%. What means that genetic screens to find the abnormal gene is mandatory for all patients with medullary thyroid carcinoma. So this is a very well-known for the audience who are in touch with the medullary thyroid carcinoma data. Is an 10-year disease-specific mortality graph. And what we show here that when the time at diagnosis is very, very important to the prognosis of this disease. So for those patients who were diagnosed and treated with thyroidectomy, when the disease is located in the thyroid gland, we see nearly 100% survival at 10-year diagnosis. These numbers drop when the disease is already spread to the neck, or the numbers are much worse, 40% of survival when the disease is already, we already have distant metastasis. So just to point to you that the surgery is the most display the most efficacy to the treatment of medullary thyroid carcinoma, and the time of the diagnosis is really critical to cure the patients. So thus you can understand the importance to do the genetic screen to identify carriers of this disease. Next. Knowing that calcitonin is the most important specific marker for medullary thyroid carcinoma, and reviewing the literature, you saw that there was some very interesting papers that already pointed for a role of immediately calcitonin, post-operative, post-surgical calcitonin, serum calcitonin as a predictive factor for free survival in medullary thyroid carcinoma. So I highlight here two papers, two manuscripts. The first one that was a very nice work that analyzed retrospectively a significant number of patients with covenantal years. So, but the drawback of this manuscript, the study, the follow-up was only 4.6 years, and this is a very indolent tumor. And the authors use the same cutoff regardless of the method used to measure the calcitonin. The other paper for the Celtic group, published in the European Journal of Endocrinology, they show that the post-operative calcitonin was a better predictor than the tumor size to show to patient associated with persistent disease progression. And the last one was a paper that was for the group of the Fernanda Weisman and Dr. Turtle, that showing that the calcitonin levels after just 1 month after surgery could be, we already show if the patient has an excellent response to the treatment. So based on those thoughts, with all the data analyzed, we ask us if the undetectable POCal calcitonin could be also a marker for long-term disease survival in patients with medullary thyroid carcinoma, because we thought that if this would be true, we could have an early marker for having a different approach for patients who had been at the very early phase of the treatment. So I now invite Dr. Rafael Scheffel to present the data of our studies.
So good morning for everyone. We are really happy to be here to discuss our paper. So going through the paper, to answer these questions that Anna just point out, we look for a cohort of patients that were followed in 2 institutions here in Brazil. Hospital de Clínicas de Porto Alegre, that is our institution, the institution that we work, and Instituto Nacional do Câncer in Rio de Janeiro. As you can see here in the map, there are 2 institutions that are not really near in Brazil, but we have a collaboration studies with INCA, that is the Instituto Nacional do Câncer, for some years. And you have able to include like 400 patients, because you have here in Hospital de Clínicas 200 patients that were followed here, and also we are a referral center for molecular tests here in Brazil. So we have patients that we have data from patients from other centers here that we can include in the study, and also in Instituto Nacional do Câncer we have some like 100 patients that are followed there. These 2 institutions are referral center for MTC treatment and are university teaching hospitals here in Brazil. So we select 400 patients to initiate a study. We have to exclude 32 in a first phase, because 28 to 28 we do not have follow-up data. 2 patients have only C-cell hyperplasia, and we will include MTC patients with diagnosis by immunochemistry, and 2 patients that have MTC but have non-calcitonin secreting tumors. After that, we have also to exclude 87 patients because we have missing data on post-operative calcitonin, that was our objective of study, or have missing data on final disease status. So we are able to include in the study 334 patients. As Anna pointed out, one of the problems from some studies in the literature was the definition of undetectable calcitonin. And since you have different methods used for the measurement of calcitonin over the years, we use a definition that was that the level below the detection level of each method was the definition of detectable calcitonin, as you can see here in the box. So each method will have a different cutoff being considered undetectable. That is the below level of that method. We measured the undetectable calcitonin in the first visit of the patient after total thyroidectomy, after surgery. That will be like 3 to 6 months after surgery. So we have a early measure of calcitonin to try to define the long-term follow-up of those patients. The disease status was the outcome of the study, was defined based on clinical examination, serum calcitonin levels, neck ultrasound, and additional imaging tests when indicated. So we define disease-free as those patients that have undetectable calcitonin and no evidence of structural disease. Biochemical disease of those patients that have only detectable calcitonin but no evidence of structural disease. Structural disease of those patients that have evidence of disease on imaging, independent of the level of calcitonin. And we also used the disease-related death of an outcome. All these outcomes were evaluated in the last visit to the clinic. So we have the measurement of calcitonin postoperative in the first visit, and we evaluated the disease status on the last visit. And we also use a composite primary endpoint that we call persistent disease, when we join biochemical disease, structural disease, and death on the same endpoint. So here you can see the first data of the study, the clinical oncological features of those patients included. So you can see that the patients have, the mean age of the patients was 41 years. The majority of the patients were female. And I highlighted here two features that I believe are important, include that because they probably impact in the results of the study, and you have to be aware of them. The first of all is that we have more than 40% of our patients being hereditary MTC. And moreover, 20% of the patients in this cohort have the diagnosis based on a screening diagnosis. Those patients that have the genetic screening after the genetic screening have the diagnosis MTC. So these two features probably could lead to a large proportion of those patients being diagnosed at the early phase of the disease. And as we see before, this could probably impact in the prognostic of these patients. Moreover, you can see here that the tumor size were 2 centimeters in median. We have almost half of the patients with lymph node metastases and almost 20% of the patients with distant metastases. And you have a follow-up of 7.7 years. Then to explore the association of post-operative calcitonin with disease prognosis, we divide the patients, the entire cohort, in two groups of patients. Those patients with undetectable post-operative calcitonin and those patients with detectable post-operative calcitonin. And you can see that those patients with undetectable post-operative calcitonin, this is the first column here, were younger, had a higher proportion of females, a higher proportion of patients with hereditary MTC, and a higher proportion of patients diagnosed after genetic screening. Moreover, they have smaller tumors with fewer lymph nodes, and you have no patients in this group of undetectable post-operative calcitonin with distant metastases. So we can see that these patients are a group of patients with probably a better prognosis, with features of better prognosis. Indeed, when you look in the bottom of the table here, you can see that in long-term follow-up, of 8 years of follow-up, 90% of the patients who are undetectable post-operative calcitonin were disease-free, and only 10% of these patients have persistent disease, and all of these patients with persistent disease have low and stable calcitonin levels. On the other hand, when you look to the patients with detectable post-operative calcitonin, only 10% of the patients were disease-free, and 90% of the patients were on persistent disease after 7 years of follow-up. We can see this data also in this graph. When you look for this graph, you can see again that the patients with undetectable post-operative calcitonin, more than 90% of them were disease-free on long-term follow-up, and those patients with persistent disease have biochemical disease. And also you can see here that the association of post-operative calcitonin and disease status on long-term remain associated independent of the rat pathogenic variant risk category. So we divided the patients in moderate, high, and highest risk pathogenic variant risk. And we can see that the association is maintained, the trend is maintained in all of these three groups. So to explore even more this relationship of post-operative calcitonin with prognostic and disease-free survival, we again divided the cohort, but now we divided the cohort due to the status of the disease. So we divided the patients in disease-free patients and patients with persistent disease. And we run first a univariate analysis, and after this, a multivariate analysis. We'll talk just about the multivariate analysis. And you can see here that you use in the multivariate analysis disease-free status as the dependent variable, so the outcome, and age of diagnosis, sex, hereditary disease, tumor size, absence of lymph nodes, and undetectable postoperatory calcitonin as independent variables, so the factor that we are looking for. And when we look for the results of this analysis, we can see that undetectable postoperatory calcitonin and younger age of diagnosis were the only independent prognostic factors for disease-free status. And the strongest associations, you can see here, is the hazard ratio of 5 was for undetectable postoperatory calcitonin. So we can say that postoperatory calcitonin was the strongest predictor for disease-free status in long-term follow-up. Looking for survival, we observe a disease-related death of almost 19% in the entire cohort, as you can see in the first graph, in the A graph here. And the majority of these deaths occur in the first 10 years of the disease. 65% of the patients die in the first 10 years of follow-up. When you divided again the patients with postoperatory calcitonin in undetectable and detectable postoperatory calcitonin, you can observe that all deaths occur in the patients with postoperatory detectable calcitonin, and no patient in the undetectable calcitonin disease died in the follow-up. And these findings were consistent when we divided the patients in hereditary and sporadic types of MTC, as you can see in graph C and D. So the keynotes of our study are that a single and early measurement of calcitonin might predict the long term of disease status in MTC patients. You can see, and we can say this with a follow-up of almost 8 years. All patients with undetectable postoperatory calcitonin remain disease-free or evolved to be stable biochemical disease at long-term follow-up, and these patients with biochemical disease have calcitonin levels that were stable over over 7 to 8 years. We use to explore this data, use various calcitonin measure methodologies with distinct reference values depending on the method that was used to measure calcitonin. And we believe that this enhances the external validity of our findings because you can use this with any method. And finally, since postoperatory calcitonin could predict the rate of disease remission and the risk of persistent disease, it may also reduce the over-follow-up effect with unnecessary surveillance, diagnostic tests, and medical appointment in these patients with MTC. So I will take to Anna now to put this in context with the literature.
So just going back to our research question, and as I said, we'd like to learn about the early measurement of postoperative calcitonin levels as an early predictor of disease outcome. And as you see here, based on the actual guidelines of the American Thyroid Association. It had been published about almost 7 years ago, but calcitonin is a key to define. The calcitonin value is a key to define the follow-up, the follow-up approach to those patients. So when you have now undetectable calcitonin levels at this flow chart, it is suggested that you continue to see the patient every 6 months with the ultrasound, neck ultrasound, and also physical examination, which means a medical visit. What we think based in our data that of course has limitations due to its retrospective analysis and other limitations that you mentioned at the manuscript. From a practical standpoint, we may use those data, if replicated in another cohorts, to make a more, to change the follow-up of those patients. Since you already know that those who have like undetectable calcitonin level, they can stay free of disease, most of them, and even those who evolve to biochemical disease, this disease does not progress to distant metastasis, structural disease, or no, and never to worst outcome that would be the death. So I finish here. So thank you very much for the attention to our study. We are very, very happy to share those data with you. And these are our email address. Feel free to contact us if any question, comments, or suggestion may arise.
Thank you very much for your presentation. Now we'll proceed with the discussion by Dr. Ghaznavi.
Hey, good morning. Thank you, everyone. I think that's a great place to leave off. I'd just like to thank the organizers for having me today. All right, so yeah, good morning. My name is Maia Ghaznavi. I'm an endocrinologist in Calgary. I'm going to be doing a discussion now. And in thinking about, these are my conflicts of interest. And thinking about, where to take this discussion, I thought there's a lot to potentially talk about in medullary thyroid cancer, a lot that's advancing in the area. And so the two things that I wanted to talk about today, just to contextualize the current study and its contribution to the literature, is medullary thyroid cancer staging and risk stratification, as well as the role of biomarkers in prognostication. So how does the calcitonin or the post-operative calcitonin fit into our current paradigm of staging and risk stratification? So this is the AJCC 8th edition staging system for medullary thyroid cancer, and it's the first edition of the staging system that sort of separates out medullary thyroid cancer from the differentiated thyroid cancer. But if it looks familiar, it's because it's quite similar to the DTC staging system, but there's a couple of sort of differences. The main is that there's no age cutoff. So in DTC, we're using 54 and under or greater than 55, and in medullary, we're not accounting for age, even though many studies actually have shown a correlation between age and prognosis. So that's something to think about. And the other two things that I wanted to point out here is stage 1 and 2 really is a homogeneous group. What's changing there is their tumor size, but not a whole lot else. And then if you look at stage 4, it's quite a heterogeneous group. So there's anywhere from N1B, so lateral neck nodes, to invasive tumors, to distant metastatic disease, which we know is a big driver of death in these patients. So it's quite a heterogeneous group, and I think that becomes quite important in the literature that we're going to look at now. So this is a paper from Korea, from Dr. Park et al., which looks at clinical validation of the prognostic stage groups of the 8th edition TNM staging system for medullary thyroid cancer. They did their study at a tertiary care hospital in Korea with 182 medullary thyroid cancer patients and a mean follow-up of just under 8 years, and their disease-specific mortality was just under 10%. And the reason I'm showing you this paper is to look at the classification of patients between TNM7 and TNM8. And if we do that, and you're looking at these two curves and you're thinking, these look very similar, it's because they are very similar. And in the change to TNM8, there's only 2% of patients that are downstaged, and the area under the curve is very similar, meaning the predictive value of the stages to predict disease-related mortality is very similar. And it's sort of moderate predictive value with AUCs that are approximating 0.7. So this really nice paper from Dr. Sosa and the group at Duke, rethinking the current American Joint Committee on Cancer TNM staging system for medullary thyroid cancer, used large database sets, so the NCDB database, and then And then later they validated their new groups on the SEER cohorts, and they used a methodology called recursive partitioning, which is a type of decision tree analysis. Now, I'm not an expert in decision tree analysis, and but I think the authors stated this point, and I thought that this was really helpful to understand what is the point of recursive partitioning, because essentially they're taking, it's a type of decision tree that finds groupings of independent variables. So groupings of things like tumor size, extrathyroidal extension, nodal status, and then that tries to predict the best prediction for the dependent variable, which in this case was overall survival. And so the authors write, cancer staging should be based on the ability to be accurately correlated with survival, maximizing the similarities in survival within groups and the differences in survival between groups. So that curve that we saw previously from POCal, where the stages 1, 2, and 3, there isn't a lot of separation of the curves. That's what this paper is trying to address and figure out a model where we can group different independent variables in order to have a better separation of survival between groups. And so on the left here is their data as sliced by the current TNM8 AJCC staging system. And on the right is their proposed TNM groupings. And you can see basically that the curves do separate. So now it's more meaningful to say whether someone is in stage 1, 2, 3, or 4. And the survival curves get worse as you go up in the stages, as you would expect. Here are the 5-year overall survivals. So in the current TNM staging system, with this data set from the NCDB database, on the left are the 5-year survivals. And then on the right, you can see that there's a better discrimination of the different stage groups and their 5-year survival. So they did this recursive partitioning, and what do they find in terms of the groupings that would make most sense? So the proposed changes that led to this curve on the right were that in stage 4, they removed T4 and N1B from stage 4, making it a less heterogeneous group, and kept only those with distant metastatic disease. They removed N1A, so central neck nodes, from stage 3 and kept just the T4 tumors. And then the N1B, so lateral neck disease, became stage 2. And with these changes, they would actually downstage a significant portion of patients. So the proportion of patients in stage 4 currently was 32% with TNM8, and with the proposed staging system was 5%. So a lot less patients, but a lot more meaningful, because you're really identifying the small cohort within stage 4 that truly has a high risk of disease-related mortality. So this next study by Dr. Cotwell et al. Was actually presented at one of the journal clubs through Think. So I encourage you to go on YouTube and watch it, because it was a great one. I learned a lot just watching that seminar. And so this is a study called Predicting Outcomes in Sporadic and Hereditary Medullary Thyroid Carcinoma over 2 decades. And it was done at the Mayo Clinic with 163 MTC patients treated between 1995 and 2015. About 40% were hereditary MTC, and I think that just reflects the referral pattern to the Mayo Clinic for these families that have MEN and other familial MTCs. Their follow-up was 5.5 years. And the reason I'm showing this study is because of the clinical pathologic variables that it talked about. So there was worse overall survival and disease-specific survival on the univariate analysis for a lot of the things that we would expect: advanced age or age greater than 55, male sex, distant metastatic disease, lateral neck nodes, invasive tumors, and increased T stage, as well as the post-operative calcitonin and CEA. So this paper also comments that this is something that's prognostic. The next part was the multivariate analysis, and in that part, basically distant metastatic disease and gross extrathecal extension, so T4A and T4B tumors, remain predictors of worse prognosis, and N1B was not significant after adjusting for distant metastatic disease. So what I found interesting about this as I was going through it is the Cotwell paper that I just presented. It basically shows that in multivariate analysis, M1 and T4 remain predictors of worse prognosis, and N1B wasn't significant on the multivariate analysis. And in the Adam paper from Duke that I showed a little earlier, they basically have kept M1 in stage 4, T4 tumors in stage 3, and then sort of downgraded the N1B tumors to stage 2. And so I think these two studies are actually reflecting each other quite well, and there's some parallels here. So we talked about some clinical pathologic variables, but what about grading? Medullary thyroid cancer is a neuroendocrine tumor, and we do grade many other neuroendocrine tumors. And so this is a really nice paper by Memorial Sloan Kettering Group, Dr. Rani Gossain, and it looks at grading of medullary thyroid cancer on the basis of tumor necrosis and high mitotic rate as an independent predictor of poor outcome. They included 144 patients treated at MSK between 1986 and 2017. And retrospectively, all the slides were reviewed by Dr. Gossain. And they showed a worse disease-specific survival, local regional free survival, and distant metastatic disease-free survival on univariate analysis for, again, a lot of the same clinical pathologic features. So male sex, larger tumors, lymph node metastases, and increased nodal size, a higher AJCC stage, but also tumor necrosis and a high mitotic index, which is defined as greater than 5 mitoses per 10 high-powered fields. Interestingly, that's the same cutoff that we use for poorly differentiated thyroid cancer, and also for postoperative calcitonin was correlated with disease-specific survival. So on multivariate analysis, essentially they said tumor necrosis and mitotic activity were independent risk factors for disease-specific survival, and there was a strong correlation between tumor size and tumor necrosis. So in this Kaplan-Meier curve, basically, I just want to show you on the right here where low grade and high grade, according to the definitions just presented, were quite discriminatory in predicting outcomes. And this is specifically disease-specific survival. So by the same group at Memorial Sloan Kettering, they looked at tumor grade and its correlation or relationship to calcitonin doubling times and showed that tumor grade predicts calcitonin doubling times in disease-specific outcomes after resection for medullary thyroid cancer. This study included 117 patients with medullary treated at MSK with median follow-up of 5.8 years. And the main thing that I wanted to bring to attention is just if you look at the low grade versus high grade, quite predictive of the calcitonin doubling time. CEA is a very similar story, but calcitonin doubling time in the high grade patients is under 1 year, which would be considered rapid, so 8.7 months. And in the low grade is greater than 2 years, which we would consider slow growth or slow doubling time, and it's 31.6 months. So I talked a little bit about the MTC AJCC staging system and risk stratification, and now I want to talk about how to incorporate biomarkers into that. So there's a lot out there when I started looking on biomarkers. The one that we're most familiar with is calcitonin and or CEA doubling times. But I think now with the current paper, it's become really important to look at the postoperative calcitonin as a single time point. And then there was all sorts of other metrics such as a ratio between preoperative and postoperative calcitonin, the basal versus stimulated calcitonin, procalcitonin, and a number of other markers that are being investigated. For time's sake, I'm going to focus on the doubling time and the postoperative calcitonin. So this is a really nice paper by Dr. Tuttle et al. At Memorial Sloan Kettering, and I think I'm presenting this because it really brings the paradigm of dynamic risk stratification and using early response to therapy to adjust your risks. So the authors write, a dynamic risk stratification system that uses response to therapy variables to adjust risk estimates over time provides more useful clinical prognostic information than static initial anatomic staging in medullary thyroid thyroid cancer. So if we look at our AJCC staging system, the TNM are static initial anatomic staging. And I think that the postoperative calcitonin is going to be a way to integrate a response to therapy into that. And so what are the responses to therapy that the authors talk about? Biomarkers, so calcitonin and CEA, as well as imaging. And here, if you look at the definitions of excellent response, biochemical incomplete, and structural incomplete, you can see that it's quite predictive of clinical outcome. With those in the excellent response category, they were those that were considered to have undetectable calcitonins. And the disease-related death amongst that group was 3% compared to if the calcitonin was detectable, 11% deaths. And of course, if there's structural disease found on imaging or biopsy proven, then 56%. Important part about this paper is that they use many different assays over the study window, and they used variable lower limit of the reference ranges, and those lower limits ranged all the way from 2 to 16. I think why that's important is because 17.5% of the patients were considered in the excellent response category or undetectable calcitonin, and someone in that group could have had a calcitonin of 1, and another person in that group could have had a calcitonin of 15. And so the overall impact of that is going to be an overestimation of the disease-related death amongst the excellent response category, because you're including some patients who, on an assay with a lower limit of detection, they would be considered to have a detectable calcitonin. So calcitonin doubling time, I think we're all familiar with this paper in JCEM by Barbet et al. In 2005 that really showed that calcitonin doubling times are well established, are established or correlated biomarkers for disease-specific survival, and that specifically a doubling time less than 2 years predicts worse outcomes. So you can see the curve at the top with the solid line is calcitonin doubling times greater than 2 years, and they only had 1 death in that group. And calcitonin doubling times between 0.5 to 2 years, you can see that the mortality begins to increase in that group. And so on with the calcitonin doubling time that's even faster, less than 0.5, had the worst outcomes. So what are some limitations of calcitonin doubling times? I think there's several, although it's obviously a good, useful marker. It has its place. I think the limitations are that it requires serial measurements over time. And at minimum, most of the authors that are using this metric are saying you need calcitonin measurements every 6 months for 2 years. So at minimum, 4 different data points. Calcitonin levels fluctuate within individuals. This is something that can be quite frustrating for patients because it's hard to tell early on whether they're just fluctuating within their own range or if it's truly rising. And I think when you only have 1 or 2 measurements, that's difficult to tell. Obviously, the assays have changed over time, and there's a significant amount of assay variability such that the calcitonin would measured at the same time on variable assays is not going to get you the same number. And then the doubling time can change significantly depending on the number of data points taken. So I myself use the Kuma Hospital tumor volume doubling time calculator online. That's how I usually do my calcitonin doubling time. And it is very interesting that as you're entering your data and you're looking at that doubling time calculated at the top of that spreadsheet, that over time, as you add more data points, it actually can change quite a bit. And I think that that's important. And should you take just the first 4 data points, so the first 2 years of follow-up, or should you take all the data points? And then the final is a little bit of a philosophical point, which I often wonder when I'm using this metric, which is it predictive or is it descriptive? Because often as the disease is taking off, the doubling time is changing significantly, but I'm watching the structural disease grow. And so I'm not sure that it was truly predictive in that it came first and told me what would happen next. Sometimes I wonder if it's just describing, the progression of disease. So the current study by Duval et al., I think, illustrates several advantages of the post-operative calcitonin. First of all, it's a single measurement in time. And so it's a very good early predictor, I think, and I'll talk about how early in a second. The use of undetectable versus the detectable category eliminates the issue of assay reference range variability across institutions and across time, as well as individual fluctuations. If you're only using one single measurement to be prognostic, you're not going to have fluctuations within individuals because it's just one time. And then I think it's been shown now through this study really nicely that it's an independent prognostic factor for recurrence-free survival and for long-term survival, and with a median follow-up in this study of 7.7 years, which is longer than most of the other papers in this area. And then undetectable postoperative calcitonin remained associated with long-term disease-free status in patients with sporadic or hereditary disease independent of their pathogenic variant risk category. So I thought those are all really important take-homes from this paper. The undetectable versus normalized postoperative calcitonin. So we've talked a lot about now the undetectable calcitonin, but can you have a slightly positive calcitonin and that's the same or it's almost as good? And so I think this paper by Fenget et al. In 2021 shows us that an undetectable calcitonin with a lower limit of 2, so less than 2, had a disease recurrence rate at a median of about 5 years of 3%, but a normalized calcitonin, so the reference range on this assay was 2 to 10, had a significantly higher disease recurrence rate of 25%. So even a minor increase in the calcitonin, which speaks to the presence of microscopic residual disease, is going to be a basis for structural disease recurrence in the future. And so I think that's why the current paper is really important to show that undetectable calcitonin is probably where we want to put our threshold for a better sort of prediction of those that will do well. It doesn't mean that if you have a detectable calcitonin that you necessarily won't do well, but if you have an undetectable calcitonin post-operatively, then certainly it's a good prognostic predictor of good outcome. So we talked about you want your calcitonin to be undetectable, but at what time point? So this paper by Dr. Tuttle and Dr. Weisman looked at time to normalization of biomarkers and essentially showed that in patients destined to have an undetectable serum calcitonin as the best response to initial therapy, the calcitonin was undetectable by 1 month after surgery in 97% of patients. So only one patient still had a detectable calcitonin, and later it fell after a month. In patients destined to have a normalized CEA, the CEA was within the reference range by 1 month postoperatively in 63%, and by 6 months in 98%. So really what this tells us is the CEA is going to be slower to come down, and you can expect the CEA at 6 months to be more predictive of which category they're in, versus the calcitonin, which is a very early predictor and of whether they're going to have an undetectable calcitonin and therefore good prognosis over time. So in summary, I think future editions of the AJCC staging system can be modified to improve the prognostic discrimination of stage groups by essentially incorporating or making the stage 4 group a bit more homogeneous with distant metastatic disease patients only, downstaging the T4 and the N1B patients, and then integrating tumor grade, high versus low. And then the integration of post-operative calcitonin as a single measurement as early as 4 weeks post-op into the initial estimate, so either into the staging system itself or as an early response to therapy like we do in differentiated thyroid cancer, can improve prognostication. And then undetectable postoperative calcitonin is strongly correlated with disease-free survival, and this holds irrespective of sporadic or hereditary disease. That's everything I've got. Thank you.
Thank you for both an incredible presentation and an incredible review of the literature. So I have more questions about MTC now than ever. So I'm gonna start with a clear basic assay question. Like, what is the assay that you're using? We saw different definitions of what undetectable calcitonin is post-op based on the chronology of when these were drawn, and Dr. Maia and Dr. Scheffel, you can speak a little bit about how that has changed and what type of assay you use or propose to be used if in lieu of using post-operative calcitonin as a marker, as an early marker of undetectable disease thereon.
Okay. First of all, thank you, Dr. Ghaznavi, for the nice review. This is a key point as we highlight in our study. The time that we treat those patients, like we made the diagnosis, is spending more than 30 years, so it started in 97. And so there are two different institutions, and during this time, a lot of different measures has been like immunoassays, chemoassays, electron, I forgot the name. So it's like different. And see, that the detection limit change, improving a lot. So I think this is also a limitation for us, because some patients that have undetectable may not be undetectable nowadays. They may have changed the detectable limit. So it's a question open to see if those patients who evolve to biochemical disease may have like detectable calcitonin and was mistakenly classified as undetectable. So this is, I think, is a really point, a good point of a study, because make it easier to everyone to use this marker to organize the follow-up, to define a therapeutic approach for those patients that have a very, very good prognosis of the disease.
Yes, thank you. I think that is key, and I applaud the effort that you guys did in defining these thresholds, because I'm speaking for me, for Mexico, for most of Latin America, and many countries, when you don't have the state of the arts to measure calcitonin, and let alone calcitonin, but molecular markers to enrich your data and see your follow-up of your patients. So I do applaud the effort that you've done. We have a question from the audience, Dr. Mark Kirk, and he makes two really, really interesting questions. He says, can you comment on whether calcitonin change reflects a change over the tumor burden, meaning volume of structural disease, or do you know if calcitonin production varies within the site of structural recurrence, meaning is it the same in bone, or if it was a lung metastasis, would it rise differently? So that would be the first question.
May I answer or try to?
Yes, of course, of course.
So for the first part of the question, yes, the calcitonin level change according to the burden of the disease. Actually, use that levels to our follow-up to decide if you're gonna check for distant metastasis or not. Usually values under 150 picomole means that the disease is located on the neck. Okay, so this is a very important information to avoid unnecessary test. I'm not aware if there is any study who looked for the calcitonin levels associated with the disease site metastasis. However, in our practice, what we observe that patient with liver metastasis has a very, very high level of calcitonin. But I want to make it very clear that is an impression. It's a good point. Maybe you can look for those data. I don't know if
yes, exactly. Sana, Rafael, do you have any other comments to add to that?
I agree with Anna, but I also think that maybe those patients with liver metastasis have metastasis in other sites, so maybe this is confounding, but I have the same impression that patients with liver disease have the higher calcitonin levels that we see in clinic. But maybe it's just an impression, and I think it's a very interesting point to look out in our data.
Yes, there are recommendations in the MTC guidelines, the laceration of them, that suggest that over a certain threshold of calcitonin, you should look for the liver, maybe even do a prophylactic surgery of the liver. But I think some of those recommendations have been, if I could use that word, inherited from old practices. And I think Dr. Akin's question goes more, if is tumoral burden in one place or the other, does that rise? Is any specific anatomical site more prone to elevate the calcitonin levels than the other? And I don't know if that's a question that research has answered just yet. Moving forward, he also asks, can you comment on whether early calcitonin predictive value is impacted by MTC grade? And I think Dr. Ghaznavi just mentioned a bit about that. What are your thoughts?
Yeah, so to answer that question, early calcitonin, postoperative calcitonin, I think we can look at the two papers by Dr. Ghaznavi et al. At MSK. And what's interesting about those papers is basically that in the high grade category, I think somewhere around 75, maybe 70 to 75% of those patients had a calcitonin doubling time that was under 1 year. They did not specifically look at a single time point, the post-operative calcitonin. So I think it would be very interesting to reanalyze these data with that in mind and look at whether that predictive value held. But essentially the doubling time established within the first 2 years, so based on 4 time points, not a single person within the high grade category had a prolonged doubling time of greater than 2 years. So I think it's obvious that they're highly correlated between the grade and the calcitonin doubling time, and that both of them sort of are predictive of outcomes. But I think it's not specifically known whether the single measurement postoperative calcitonin is, and that's why I think the current paper is important, because it's changing, what metric that we're looking at as a single time point very early on to adjust our risk estimates.
Thank you. I have a quick question. It's a personal wondering, I guess. Calcitonin is a biomarker that's measured preoperatively in some places, not widely spread. But are you aware of any research that has evaluated the change between the pre-op and the post-op as a biomarker of disease-free survival, or disease not having a recurrence or progression of the disease? I mean, you go ahead.
No, I think Dr. okay, Shana, okay, it's easier, may answer that. I saw that he listed this ratio as some markers. So I'm also interested to learn about that.
In the Andrade and Tuttle research that was presented, yes. Is there any protocol that they used, or are you aware of the protocol that they use to evaluate the delta, if I may say, or the time to normalization of the biomarker?
Yeah, so part of this is from my clinical experience just training at MSK, and part of it is from the literature. So there are studies that are looking at the ratio between the preoperative and the postoperative calcitonin as a single time points, and then looking at that ratio. So if you think about this from sort of an intuitive level, if your preoperative calcitonin is very high, that's indicative of overall tumor burden. And so either you can have a very large tumor with some likely to have nodal metastases, or you have distant metastatic disease that's going to be persistent post-operatively, because you're obviously doing a local control strategy with the thyroidectomy. So compare that to the post-operative thyroid globulin. I think if the ratio is very high, meaning that there's been a big drop and now you have it, for example, an undetectable calcitonin post-operatively, it's really, basically strongly predictive that you're going to do well, but and it's usually only going to be seen in those tumors that are either somehow intrathyroidal or that there was lymph node metastases that were able to be completely resected. So it's really speaking to the completeness of surgical resection, which obviously is not going to be possible if the disease has spread to a distant site, right? So I think that's one. And then the second, in terms of the protocol, you know, it's in my anecdotal experience with fellowship with Dr. Tuttle, what we would do is always get a preoperative calcitonin. I think that is important and is guideline oriented, basically to have an understanding of whether you're considering that it's all localized to the neck or if it's spread to a distant site. So I think it's prognostic, but also will help you understand whether you know, you need additional cross-sectional imaging and that sort of thing to plan out the appropriate surgery in the first place. So first is we always got a preoperative calcitonin when the diagnosis was known. Obviously, in some cases, these are biopsied as indeterminate nodules, aus flus, and in that case, the person goes for a diagnostic and you don't know the diagnosis beforehand. So when you do the preoperative calcitonin, then the second thing is, because of that assay variability that we talked about, Dr. Tuttle's practice was to do a postoperative calcitonin first at 1 month and then to do 2 more measurements within the next month. So he would actually average the calcitonins, 3 calcitonin measurements over the first 2 months, basically, of post-op. And that was because there's some, potentially some are still coming down, although their paper would speak otherwise and say 98% of patients, it's already dropped by the time it's 4 weeks post-op, but also to really account for some assay variability within the same individual, or some variability in the calcitonin level within the same individual. So, and then we would use those 2 measurements, but not as a ratio, more just, you know, independent, sort of predicting the extent of disease and then the completeness of surgical resection.
Thank you. That's really informative and helpful for the clinical practice. I can't thank you all enough for your presentations. I wish we could stay here for another hour. I mean, the idea of the recursive partitioning that you brought just blew my head out of the water. I definitely have to read up on that. I can't thank you enough, Dr. Maia, Rafael, Sana. Thank you for being here. And I do want to invite the audience to be here next week. We're going to have an incredible tumor board with Dr. Fabian Pitoya from Buenos Aires presenting cases, and Dr. Mike Tuttle moderating these with a great panel. So thank you all for being here. Incredible presentations, a lot of food for thought, and I guess I'll keep on reading on this for a little while now.